Good morning, and thank you for joining today's webinar. I'm Dr. Heidi Leftwich from the University of Massachusetts and the SMFM Education Committee. In recognition of Black Maternal Health Week, I'd like to welcome everyone to this special SMFM webinar on COVID-19 and health inequities presented by Dr. Sarahn Wheeler and Dr. Allison Bryant. Before we begin, I'd like to take a moment to share a few housekeeping notes on today's webinar. This webinar is being recorded and will be available to view on demand from the SMFM website. Following the lecture, there will be a 20-minute question and answer segment, and you may enter your questions through the Q&A box at the bottom of your screen at any point during the broadcast. Please refrain from using the chat feature to ask panelists questions. We promise to get to as many questions as possible as time allows. A brief introduction for our speakers. Dr. Wheeler is an assistant professor in the Duke University School of Medicine, Division of Maternal-Fetal Medicine. Her current research focuses on racial disparities in preterm birth. Dr. Wheeler also serves as the Director of Diversity and Inclusion for the OBGYN department at Duke University, as well as serves as a member on the SMFM Diversity in the Workforce Committee. Dr. Bryant is an associate professor of obstetrics and gynecology and reproductive biology at Harvard Medical School and is vice chair of quality, equity, and safety in the Department of OBGYN at Massachusetts General Hospital. She is also a member of our SMFM Diversity in the Workforce Committee. With that, I'd like to welcome these accomplished speakers for their time and begin our webinar.
Thank you so much for that kind introduction. It's wonderful to be with all of you, and I really want to thank the Society for Maternal-Fetal Medicine for creating this platform and this space for us to discuss a very important aspect of the COVID-19 epidemic, health inequities, and COVID-19. Trying to get my slides to advance here. So I want to talk to you about three really important take-home messages about health inequities and COVID-19. First, I'm going to highlight some current data on health inequities, what we know, and in some cases what we don't know about some special populations for considerations. I also would like to talk about why these COVID-19 inequities exist, and then what we can do about it and some take-home points as we're providing care on the front lines day to day. With respect to the specific populations that I'd like to highlight, certainly we know that there are many groups that we could be talking about during this webinar, but I'm going to focus my comments on racial and ethnic minorities, sexual and gender minorities, and then people who are suffering from intimate partner violence. The CDC actually came under quite a bit of fire because there was very limited data that was being published that actually disclosed any racial or ethnic characteristics of people who have been diagnosed and people who have succumbed to the COVID-19 pandemic. The first data that we got from the CDC was actually published fairly recently on April 8th. This report included 14 states that were actually recording racial and ethnic data, and it only includes 580 patients. And I think that's important to note as I'm presenting all of this data, is these data are all based on relatively small numbers, and we're learning more and more each day. When we got that initial data, what we saw was that about 45% of the people who were hospitalized due to COVID-19 with laboratory confirmed cases were non-Hispanic white, and about 33% were non-Hispanic Black. The rest in smaller percentages were self-described as Hispanic, Asian, or unknown. And you'll note that they're combining both race and ethnicity within their categorizations here. When we compare what those numbers look like to the overall US population, that's where some interesting disparities really do start to unfold. Here I've put down two graphs, one on the left being the CDC data on the COVID-19 epidemic, and on the right here you have some data that I've pulled with general US Census population information. And what you can see colored in blue is that although people who are self-described as white make up 72.4% of the US population, they're actually only 45% of the people who've been hospitalized with COVID-19 thus far. And as comparison, people who self-describe as non-Hispanic Black or African American are about 12.6 or about 13% of the US population. They are 33% of the population that has been hospitalized with COVID-19. This is further reflected in the numbers that have been published in terms of COVID-19 deaths by race. This is a figure taken from an LA Times article that made a pretty big splash, as it should have, looking at the disparity between Black and white deaths with respect to COVID-19 in certain select states in the United States. We're fortunate in North Carolina, my home state, in that our data is actually being collected and reported by race. And here you can see that North Carolina is not spared by these disparities that I have highlighted, in that white people in North Carolina make up almost 70% of the population, but yet only 55 to 58% of the cases and then deaths, while Black or African American are 21% of the North Carolina population, but nearly 40% of both the cases and the deaths. Another important aspect of health inequities to note as we're dealing with the COVID-19 epidemic is there's also been an uptick in xenophobia that's been targeted at our Asian American colleagues and patients. There's been an uptick in this idea of fear or hatred of people from other countries. And this picture that I've shown here is actually from a New York City subway, where this has been highlighted as such an issue, where they've actually hung up signs to highlight that these types of sentiments should not be tolerated under any circumstance. There was another newspaper article that actually attempted to measure some of the sentiments that have been expressed even worldwide. Here what you can see is that unfortunately the United States and Canada is leading the way in terms of some of the unfavorable sentiments towards China and Chinese Americans. The next patient population that I want to specifically talk about are our non-English speaking patients. Importantly, this has also gained a lot of attention in the news, as it should. We know that approximately 1 in 5 Americans speak a language other than English at home. And we know that this patient population, just as in any other circumstances in healthcare, are often more susceptible to health inequities, and certainly COVID-19 is likely to be no exception. We also know that starting in 1964, the Civil Rights Act requires that all hospitals that receive federal funds should be providing interpreter services to their patients. And this has not changed even in light of the COVID epidemic. Obviously, there were previously barriers and difficulties with providing interpreter services at many of the facilities where we work and serve patients, and certainly the COVID epidemic has not made that any easier. However, I want to highlight that there's been specifically some things written in the news about how language barriers have actually exacerbated and led to sometimes even improper care. There was one specific example of a story where a physician was doing their best trying to communicate with a non-English speaking patient, actually had an interaction where they misunderstood the patient and admitted the patient when they actually probably didn't meet admission criteria. So this not only it leads to poor care, but it can also lead to inappropriate resource allocation. Along those same lines, there have been increasing concerns, again appropriately so, about our undocumented patient population. The United States Citizen and Immigration Services did release a statement reporting that they are encouraging all people who are undocumented who do have symptoms of COVID-19 to seek all necessary treatments and preventative services, and that seeking these services will not negatively affect their future public charge analysis. The reason why that's important is in evaluating whether or not undocumented persons are allowed to stay in the country, oftentimes whether or not they have relied on any type of public programs comes into their ability to competitively be selected for those types of entry into the country. And so there was a lot of concern that if undocumented immigrants were utilizing free testing services, that would end up negatively harming them, or utilizing, as I've documented here, supplemental nutrition programs that would end up being negatively counted against them. And importantly, there have been promises made that that will not happen. It's also important to realize that a lot of the economic relief that's been published in the news, specifically the CARES Act and the over $1 trillion in economic relief, may very well not reach our undocumented immigrants or their families. And also it's been highlighted in the news that there's high risk for COVID-19 outbreaks in some of the ICE detention facilities as well. Further, I wanted to highlight the LGBTQ community. This is an area where we have very limited data in terms of how the LGBTQ community is being affected by the COVID-19 epidemic, but we certainly have significant reason to be mindful of this population as we're going forward with our response. We know that LGBTQ people are more likely to work in industries that are highly affected by COVID-19, from the restaurant and food service industries, hospitals, and retail. We also know from published data that LGBTQ people are more likely to have less financial resources. And specifically, there's been important attention paid to LGBTQ youth who are at very high risk during this time of social distancing, where they may be quarantined with family members, where there may be tense family relationships due to their sexual orientation. The New York Times very recently put out a really important article highlighting another important population, and that's victims of intimate partner violence. In this article, they highlight that there is a worldwide epidemic surrounding domestic and intimate partner violence as we face the COVID-19 epidemic. They point out that, again, this is not something that is surprising to most people who are versed in this topic. We know that even at times of holidays and summer vacations, that there's oftentimes an uptick in domestic violence, and that has been the case as well during the COVID-19 epidemic. So much so that, in fact, the UN has now called on this to be a worldwide priority area for victims of intimate partner violence. In the setting of pregnancy and the patients that we take care of, this has always been that much more important and continues to be during COVID-19. We know that even under typical circumstances, over 300,000 pregnant women each year are victims of intimate partner violence, and that homicide is the leading cause of death for pregnant women. We also know that about 50 to 75% of women who were abused before pregnancy continue to be abused during pregnancy. So those women who have a history of intimate partner violence documented in their chart bear special consideration. And we also know, importantly, that the vast majority of homicides that occur during pregnancy actually occur during early pregnancy, when we're less often to have frequent contact with our patients. So an important consideration as well. I did want to highlight that even in light of the COVID epidemic, there are still very important resources that are available to us as providers and to our patients as well. Depending on the state, there may be fewer resources that are available. Some of the emergency shelters are becoming highly overrun, given the increase in intimate partner violence. There may be more limited resources for legal action as well. However, there are still some important resources, and I wanted to highlight specifically the National Domestic Violence Hotline, which is still very much up and running. Patients can, or anyone who is affected, can text Love Is to 22522, and that will connect them to help and resources. And to note that this is a free, bilingual, it's both in English and in Spanish, 24/7 confidential service that is being offered. I've spent a lot of time talking about numbers and different populations that bear our special attention during this pandemic. I wanted to spend next a few moments talking about why these disparities or inequities that we're seeing exist. And I think the overarching thing to really take away from this is most of us who think about and do disparities work, none of us are terribly surprised by what we're seeing. You take a system that was, as I mentioned, already imperfect, where disparities already exist, and then impose an epidemic such as this, and it's not surprising that many of the disparities that we've seen throughout history in healthcare are also true within the COVID-19 epidemic. And just as we tend to use this paradigm of patient, provider, and policy level factors that contribute to many disparities, I think that same paradigm is helpful in thinking about the COVID-19 epidemic as well. So with respect to patient level factors, I think many of the social determinants of health that disproportionately impact some of the patient populations that I've highlighted are very much at play within the COVID-19 epidemic. We know that many of the communities we've spoken about are at higher risk for many of the baseline comorbidities, whether it's diabetes, obesity, heart disease, that are known to be exacerbators of the COVID-19 virus. Additionally, many of the people in the groups that we've spoken about are also more likely to be in employment statuses that are impacted by COVID-19, whether that's unemployment or remaining employed in the healthcare system, the grocery stores, et cetera, and places where they're much more likely to be exposed. It's also important to note that many of you are probably aware that there are several myths that have circulated around different communities, most notably in the African American community due to the lower incidence that we were seeing in African countries initially. Myths started circulating that people of African descent might not be as high risk for COVID-19. And part of that was also probably perpetuated by inequities in testing, in that people in these communities weren't getting tested as often. And so unfortunately, these myths started and they have perpetuated. So much so that many local health departments are now having messages that are broadcast specifically to the African American population to try and dispel these myths. Also, unfortunately, the healthcare system has earned a lot of mistrust from many of the populations that we've spoken about as well. And there's oftentimes mistrust and concern when that there's profiling and or mistreatment, even when patients are approached about being tested. We've even noted that some of that in our Duke population as well. Next sort of category that we'll talk about is provider level factors. We know that under the COVID-19 epidemic that our healthcare providers are being stretched to the max. And that exhaustion, that fatigue, and the anxiety that is being created by this epidemic increases our own risk to being biased towards different patient populations. And I think that bears some special attention and a really intentional and purposeful approach to trying to mitigate that response. Also, there are many providers, especially depending on when providers were trained, who've had limited access thus far to cultural competency training and key skills that can be helpful in mitigating bias. And then again, we're in a setting where there's just more limited resources, and it's always challenging as limited resources become scarce to ensure that they are equitably allocated. Then finally, of course, there are policy level factors. I've already alluded to some of the limited limitations in data collection. Many states and many areas are not even collecting data by race, and without that data, we're limited in our ability to understand the level of inequities that we're seeing, and therefore our ability to respond to them. We also are continually being mindful and need to be mindful of inequitable resource allocation, whether that's testing to hospital beds, to ventilators, to PPE equipment. And then limited transparency in policies. There's been a lot of moving pieces at the policy level in terms of consolidating clinic appointments, closing different clinic sites, and without transparency in terms of how those decisions are made, different populations are at risk for being disproportionately impacted by decisions that are made at the highest levels. I want to leave you with some basic broad ideas of what we all can be doing in our individual day-to-day practice and within our clinical environments, and how we can each be agents of change to ameliorate these inequities as we face the COVID-19 crisis. So 3 major points again, providing high quality, equitable, culturally competent care is at the core, caring for each other and maintaining a culture of inclusion, and then finally advocating to our leadership for all of our patients. In terms of providing equitable and culturally competent care, one of the first things that I'd like to highlight is ensuring that we are keeping a lens of equity as opposed to equality at the heart of our response. I love this picture in this graphic. I think it so beautifully displays how giving everyone the same thing does not necessarily lead to the outcome that we truly want for everyone that's involved. And this, of all times, is certainly a time where equity is so important, in that certain patients, certain populations may need a different response than other patients and other populations, and it may not be a one-size-fits-all as we're responding to this pandemic. I also want to highlight that it's so important that we are all utilizing effective cross-cultural communication skills. As we approach that, I think it's really important to start from a place of humility and curiosity. If a patient is expressing a concern to you that at first may seem outlandish or are incomprehensible, it's important to note that a lot of these things are actually based on very real experiences. For example, in the African American community, there's been a lot of concern about covering your face because it can increase your risk of profiling and violence with police and other authorities. And in fact, there's even been some cases where people have been profiled in stores due to wearing a bandana and et cetera. And another important skill that can help us as we endeavor to do this is perspective taking. It sounds simple, but putting yourself in your patient's shoes and really trying to be intentional about thinking, if I were my patient right now, what are the things that I would be thinking? What are the concerns that I would have? And be proactive about checking in with the patient about whether or not you've hit the mark appropriately and how you can help to navigate those questions and concerns. As we think about maintaining a culture of inclusion, incredibly important, number one, that there's absolutely no tolerance for racism or xenophobia at any point, and that we are at the forefront as leaders in healthcare, that we are ensuring that that culture is there. I want to highlight, we've spoken before, even at the SMFM meeting, about upstander skills, and I think that those can be very helpful. And being vigilant as you're hearing these othering attitudes and rhetoric in terms of other groups of people and the way that people are referred to and spoken about, because we know that those things then can perpetuate violence and bias. As we talk about bystander and upstander skills, I just wanted to briefly remind our membership about the 4 Ds that we can use with our colleagues and within our clinical environment, whether it's directly approaching someone who has said or done something that's of concern, a delayed approach such that we're approaching them maybe at the end of the day or sometime later when it seems more appropriate, delegating even that response to another team member or someone who may be more appropriate to respond. And then I always like to highlight this picture down here is of the potato chip man who gained fame in New York City by simply distracting 2 people who were in the middle of a physical altercation on the New York City subway, and how important that technique can be as well. And then 3 important Ds to avoid being defensive, even if you yourself find yourself to be on the receiving end of feedback about something that you might have said or done. Avoid being overly dogmatic as you are approaching someone. You may not know all the nuances of the situation. And certainly, again, we are all more susceptible to behavior that we're not as proud of when we're in this type of highly stressed situation. And then finally, to most importantly, avoid doing nothing. Then the last thing I'll say is certainly advocacy. Important that we're advocating at all levels, whether it's our institution at the state level and at the national level, and that we're advocating on multiple fronts, whether it's access to care, resource allocation, as we've discussed, and importantly, policymaking. So with that, I'm going to close because I want to make sure that I'm giving Dr. Bryant enough time to render her comments. I want to thank again the Society for Maternal-Fetal Medicine, the Diversity in the Workforce Committee, my institution, and all the people who are helpful with putting this together. And I look forward to any questions after Dr. Bryant's talk.
Great. Thank you so much, Dr. Wheeler. That was amazing. I will share your gratitude to the Society for making this a priority for us today. So my hope today was to sort of follow up with some comments a little bit about some practical considerations that we've considered at our institution and around the country that I've heard, and just to give you guys some ideas and thoughts for where you might be able to take this, this back to your homes. I do want to sort of echo the thought, first of all, that I have no financial disclosures, but what for many of you who've heard me talk before, my one disclosure is always that I am a native New Yorker and I talk really fast. But today I'm bringing this up, yes, because I talk really fast, but also just to say that sort of my heart and my soul and my family are in New York. And obviously we've all been watching what's been happening there as the epicenter in the country. I also want to remind everyone again that this is Black Maternal Health Week, and so I think that this is well situated to be talked about this week, and wanted to sort of draw people's attention to the Black Mamas Matter Alliance and the many events and webinars that are going on this week, because this is an issue that is going to be going on beyond COVID and has been going on before COVID, and this is an organization that's really done a lot of work to try to get us all up to speed. As we all know, the maternal mortality crisis sort of has been looming, and the disparities in that sort of predated this COVID pandemic, and I think that we will continue to see the legacy of this afterwards. And so when I talk about health inequities, I oftentimes sort of show this graphic that I like to sort of lay the stage, as Dr. Wheeler already pointed out, sort of where we think inequities arise. And they really can arise at the patient level factors, the provider level factors, those intersect at the level of the clinical encounter, and all of that exists in the broader healthcare system. But what I sort of adapted this to include really is the structural factors. And what I always say is that if this were drawn to scale, the structural factors would clearly sort of overrun all of the other factors. And I think that that is no more true than in the COVID epidemic, because COVID clearly is very much an infectious disease, but it is also very much a social disease. So things like poverty and wealth, stability of housing, food security, and racism all will play a huge role in how this disease plays out. I do want to remind folks of why I think that racism matters. So we spend a lot of time, and I will spend a lot of time in the rest of this talk, talking a little bit about social determinants of health. And I think that those are very important. But I think it's really important to think about both that social determinants of health influence folks' health outcomes, but they really are predated oftentimes by racism and structural racism, institutional racism that cause things like neighborhood segregation or inadequate access to health services or poor housing or transportation. And so as we think about COVID and think really about the fact that how women or how patients do in the COVID epidemic is informed in some ways by pre-existing conditions like diabetes, hypertension, and asthma. Those things themselves has predecessors in social determinants. And then again, those are backed up to institutional racism. So it's just important to remember where this all comes from. So what really is the problem? If you frame the problem in terms of equity in the time of COVID, Dr. Wheeler pointed out a number of these things, but really that there's an inequity in the burden and the consequences of this disease. And that the living and working circumstances of many of our patients make social distancing and in-home isolation challenging. If we think back to when we first started to hear about COVID and some of the public health messaging that was delivered about hand washing and sneezing into your elbow and social distancing and wearing a mask or not wearing a mask, most of those messages were delivered primarily up front in English, which sort of disadvantaged our patients of limited English proficiency. We certainly know that access to testing has not been uniform by population. We heard as well already that the prevention mechanism, so namely home confinement, really has increased the risk for gender-based violence and other mistreatment, particularly for those who are living on the margins. And then as we just said, that comorbid conditions are not equally distributed in the United States, really due to longstanding inequities in access and quality of care. And so in our sphere, these concerns were already sort of overlaying the sort of vulnerable place of maternal mortality and the severe maternal morbidity crisis, particularly for Black women. I am not a Twitter follower in general, but I was very, I think that these two tweets from two twins who are also native New Yorkers, also fellow Harvard College and Harvard Medical School alums, who Uche Blackstock is in emergency medicine trained and now working in New York and has left academic medicine to develop a company called Advancing Health Equity. I think that her messaging is really clear that racism and not race is the risk factor for the overrepresentation of Black COVID-19 cases in mortality in the United States. And this is a crisis within a crisis. And her sister, Oni Blackstock, who is trained in internal medicine and HIV and works in the Bureau of HIV Prevention in the New York City Department of Public Health, really likens it to the HIV epidemic, which we had sort of referred to as an epidemic of inequality, and that COVID-19 really is a pandemic of inequality, and remembering that epidemics track along the fissures of society. So what I'd like to sort of turn to a little bit is just some practical considerations for you and your units as you think about how we can think about trying to equitably provide care for all of our patients. The one thing that I will say is that I feel like the equity considerations really need to be both upfront and they need to be intentional. And so I sort of applaud folks who are thinking about this, people who are participating in this webinar in terms of thinking about how we can infuse equity, because I really think it needs to be infused every single step of the way. So as any policy is being rolled out with respect to COVID in your institutions, someone needs to be at the table to sort of say, how is this going to affect all of our populations? So we at our institution have a broader umbrella. There is already a Mass General Equity and Community Health COVID task force for the entire institution that meets on a weekly basis to consider these things. And we have the same in our own population, in our own department. So we have our own subgroup of a COVID task force. And so a lot of the work that I'm talking about now really comes from those two groups. And so I want to pay homage to all the hard work that folks have been doing to try to consider how we can best care for our populations. So just to lay the stage a little bit about where we are practicing. So I work in a hospital in Boston, and the Boston Public Health Commission has published sort of rates of COVID by neighborhood in Boston. And what you can see here is that those areas that are darker on this map represent those parts of the city with highest prevalence of COVID-19, and tend to be also those neighborhoods that serve African-American patients at a proportion to the other neighborhoods in Boston. But we serve the greater Boston area in our hospital, and what has really emerged for us is this sort of story of Chelsea, Massachusetts as being a hotspot for COVID in the greater Boston area. And so I have used this slide in other talks to talk about the fact that we serve a large population of women who live in Chelsea, and that while it's only 5 miles as the crow flies from Mass General Hospital, women need to sort of cross the Tobin Bridge to get to us, and sometimes that feels like a world away. And partly that's because we have a health center that is really a one-stop shop that provides wonderful service to the folks in the community. It has behavioral health, it has nutrition, it has x-ray, it has, you know, anything that you would need in an outpatient center. And so sometimes the idea of crossing the bridge to come to MGH for delivery is sometimes daunting for some of our patients. But what we know now, as of last week, was that the city of Chelsea has the highest rate of COVID-19 in Massachusetts, with rates that are about 3 times as high as the general Massachusetts population. So why is that? What does Chelsea look like? So Chelsea's population is 68% Latino, and it is 68% are US citizens, so lower than the rest of Massachusetts. Great many people in Chelsea live below the poverty limit, particularly in our Latinx population. And then if we think about the sources of work for the Chelsea residents, they are many workplaces that either were considered to be essential work, or places that had maybe not had, you know, things like sick pay, so that folks, you know, would perhaps be more inclined to show up to work symptomatic for fear of sort of losing their jobs. And I think that this sector that looks like it's big in terms of healthcare and social assistance, I think is important to think about breaking down. So this comes from a monograph that I just got today, actually from McKinsey, thinking about Black Americans in the United States and where they work. And so if we think about the fact that Black Americans are overrepresented in 9 of the 10 lowest wage jobs considered to be high contact and essential services, a number of these things in that top graph are things that we would consider to be healthcare. So psychiatric aides, orderlies, nursing assistants, pharmacy techs, medical assistants. So it is not necessarily the doctors and the nurses that are overrepresented in these populations, but tends to be maybe the lower wage earners within the healthcare systems. As we think about this, we need to be thinking about everyone who also works in our office and sort of the neighborhood that they come from. This is not unique to us in Massachusetts. I think this is a similar story to what we were seeing in places like Jackson Heights and Elmhurst in New York City, that are places that have high populations of immigrants in particular. So as we as our committee have thought about what is to be done, these are sort of the larger domains that we thought were very important for us to consider as we sort of move through this work together. And so I just want to take you through some of them, and I'm obviously open to questions at the end. So when we think about clinical care, some of the equity considerations is just that as we space out our outpatient visits, that may not be a strategy that works well for all of our populations. And so particularly for those who have complex both medical needs and social needs, you know, spacing out from 12 to 20 weeks may be a huge gap in time for people who have, say, diabetes and newly unstable housing, and may have issues in terms of refrigeration of insulin and things like that. We also know that there's probably going to be differential access to and uptake of electronic communication. So we already knew before this from our own internal data that our patients of color were less likely to be enrolled in our sort of electronic messaging system, and that has only been exacerbated in this epidemic. The ability to use medical interpreters for virtual visits was a little bit of a dicey consideration, and we're worried that that might diminish the quality of the telehealth visits. And then we also don't really know how much access our patients have to adequate MITs and data for their devices. We also think, you know, as Sarahn mentioned, so poor health literacy, fear of losing employment, and definitely mistrust of the medical system and the government may affect when people show up to care. And we know that as resources are scarce, so with for testing as well as for treatment for COVID, including things like ventilators, the algorithms that we use may be inadvertently disproportionately disadvantaging our underserved population. I'm just going to move on in the interest of time. So some of the solutions that we have thought about in our institution is just really making sure that all messaging is available in multiple languages, and that includes to our workforce. So in our institution, we have many of our workforce for whom English is not their primary language. So for all the blasts that have gone out to employees, they are now going out in multiple languages as well. We also are going to work with our institution really to understand the language capacity of our providers and staff. So a survey was sent out throughout the institution to understand the facility of folks in terms of other languages so that they might be able to be part of the solution. So we are going to try to include or offer folks language concordant telehealth visits, so we eliminate that barrier of the interpreter if there needs to be one. And then also there is like a Spanish language care team at MGH that is clinicians who speak Spanish who can round with teams or do discharge planning or do follow-up telephone calls as well. I think at the beginning of this pandemic, we thought about sort of downstaffing many of our practices so that we could cohort groups of providers. But I think that really what we're recognizing is there are some places, particularly our Chelsea Health Center, where we really do need to do some more upstaffing. And then we also just need to redefine priority populations for COVID testing. So now in our institution, being a resident of Chelsea is one of the criteria that we are considering in terms of offering testing. And sorry. The other thing that we have thought of, I'm sure many of you who might be at academic medical centers or have medical students don't have medical students in this moment. And the medical students really are looking for extensions of their education in ways that they can be helpful. So we are likely to roll out a program whereby medical students may provide extra touches to patients during the times when they're not coming in for inpatient visits. So not to take the place of clinical visits, but really just to check in and get some education about basic OB, and hopefully it'll be a win-win for all. We know that part of our telehealth programming is having blood pressure cuffs done remotely. And so we have secured a philanthropic donation of blood pressure cuffs so that we can provide those to patients who need them. We have talked to our community health team just to understand in the communities how women really want to be contacted so that we are not making assumptions. And what we found is that some patients really want to be sent a text message. So text messaging is the way that they are most easily able to be reached. And so sometimes we'll reach out by text to sort of set up the next visit. I think in terms of community health and engagement, this is really, I think, where it's at and is super important. I think that we know that those social determinants of health that are barriers to health and well-being are clearly exaggerated in this, this climate. And then we've already talked about intimate partner violence in this population. So things that we've thought about in terms of equity solutions is if you guys are not already screening for social determinants of health, I would really encourage you to add that into your practice and really understand that this is going to be dynamic so that the woman who is not food insecure at the first trimester visit may certainly be food insecure by the time the third trimester rolls around. So really trying to screen early and often. And as best as you can, understand your social work, your community resource capacity within your institutions to understand who you will turn to for help, including local food banks and housing resources. So we know that our local food bank, particularly in Chelsea, now has the availability to give out things like hand sanitizer and other products. Our institution, you can see in this picture, is putting together these kits to send people home with either from the emergency department or folks who are going to some of the housing resources to do sort of convalescent care to make sure that they have what they need. We certainly have increased our touches of intimate partner violence screening and sort of screening for at-home safety. So asking almost at every encounter, if we can, are you in fact safe at home? And can you safely practice social distancing? And then really what we have found is that we are leveraging community resources and things like Spanish language television. So one of our bilingual midwives is going to do a piece on Telemundo to really get out healthcare messaging where patients are. We really felt like it was important to think about reproductive justice and make sure that that was very much central to the work that we were doing, because understanding that in times of crisis, there are threats to reproductive justice, particularly for low-income women and those of color. And so some of what that's looked like is that, we've had national guidance, some of which we've all been, part of creating, talking about things like tubal ligations and maybe considering that to be something that could be pushed outside of the COVID pandemic. But I think we all need to recognize that there are women, particularly undocumented women, for whom, pregnancy is the time when they have financial access to healthcare services. And so if that is in someone's reproductive life plan and they're not likely to be able to access that once this pandemic is over, being flexible with that in terms of thinking about sterilization on labor and delivery. And then obviously many of our professional societies have appropriately continued to advocate for access to abortion care as essential services. Sarahn talked a bit about bias and mistreatment. I think that this is very important, and this we knew a lot about before we started this pandemic, and it's only getting worse. So in times of crisis, clinician and system biases may be exaggerated. And we certainly know that there has been an uptick in xenophobia and racism, particularly towards Asian Americans in our communities. And so what we have done is really just raise awareness. We have done, bias training before, but we have sort of reminded folks that this is a time when their biases sort of may show themselves. We want folks to really understand the legacies of mistrust and where they come from, and approach all patients and families with some cultural humility. And then if you have it available to you, which we had just sort of gotten started before this, consider some mechanisms by which patients and bystanders can report these experience to witnesses, this experience or witnesses instances of bias, microaggressions, or racism. I think in terms of data reporting, I think this is really kind of critical, and Sarahn mentioned this in the advocacy piece. So I think that both we're going to see, we know that we had inequities in sort of COVID-related outcomes, but also probably non-COVID related outcomes that we need to continue to collect. And so we just need to be vigilant by collecting our data by race, ethnicity, by language, by payer, are the ways that we stratify our data. And then I think that this is important and sometimes gets lost in the shuffle for those places that are engaged in research. I think there's a lot of great research that's going to come out of this pandemic so that we'll have a better understanding going forward. But I think it will be a crime if we don't include those populations that are most vulnerable in these research efforts. And so also recognizing that certain communities may have had poor experiences with research in the past, leading to often sort of totally well-deserved mistrust of sort of the research infrastructure. And so towards that end, sort of engaging diverse and multilingual study recruitment staff is going to be important. We got an all, MGH blast, sort of looking for bilingual, particularly Spanish speaking research assistants or recruiters. And I think that that's going to be critical. Certainly we've heard stories about studies, quote unquote, that are happening without IRB reviews, so being really quite vigilant about that. And then really ultimately designing and conducting some studies with community input and participation from its very start. And then I think close to my end, sort of ending with thinking about philanthropy. So, I think many of us on social media or in the communities which we live, know that there are many people who really want to be helping out in this time and want to be helping healthcare providers in particular. I would say, we definitely get, food trays that come up to labor and delivery, and that really sort of then targets the providers and the nurses who honestly, in many instances, are people who could afford to bring a healthy lunch to work on their own, and it doesn't necessarily get to the folks in the hospital that we talked about before who may be living on the margins. And so as you think about that, as you hear from people who want to give or be helpful, think about the entire institution and also the communities that we are living and working in. So also you can consider your own internal drive to support local communities, either through community-based organizations, thinking about donating data plans or phone minutes to patients who might need them. And then we have thought about whether or not we would want to do something like third trimester donations for new parents. So things like baby clothes and diapers and diaper drives and things like that, that will be a sort of tangible support to the patients who most need it. And then lastly, never forgetting about policy and advocacy. So I think that we all will need to make time for this. I think that our voices are going to be very important in this story. So as we hear more on the national level and on the regional level and in your states, lending your voice, even if it's just in a letter writing campaigns or, giving testimony to what's been happening for our patients living on the margins. And so with that, I will end and happy to take questions. I want to lend a special thank you to our MGH Department of OB/GYN Equity and COVID Working Group. Same thing at the institutional level, to my entire division at MGH and to SMFM for hosting this. So thank you guys so much.
Great, thank you so much. We want to welcome questions under the Q&A. I know that people have probably been listening so intently and haven't had a chance to put in some, but I have one from the chat box that I'll grab first. It says, I noticed in Dr. Wheeler's slides that COVID data has Hispanic patients split out as a separate category. However, population breakdown data did not include a separate grouping for Hispanic patients. Are Hispanic people more likely included within the white grouping, and would that change how COVID impact data is interpreted? Sorry, that's a little bit long, but I think is an important point.
Yeah, no, that's an excellent question. So I think what the question is referring to is some of the pie charts that I showed. And I think really what the heart of that question is the data that we get depends on how we ask the questions. And I think most often really the gold standard really should be that we are asking race and ethnicity as separate constructs. Oftentimes those things get grouped together and then we are at the mercy of the data that we have collected. Importantly, in the North Carolina data they are asking those two things separately. In the data, in my review of the CDC data, it looked like those things were being grouped together. So hopefully we will have more granular data. Dr. Bryant even made the point about we need data in terms of socioeconomic status, payer status, language status, all of those things. And at the end of the day, we're only going to know the answers to the questions that we've asked. So it's certainly an important point, and one that we hope will continue to be highlighted as we're collecting more data.
And this is Allison. I would echo that and just sort of say, you know, as you read the literature, as you read things in papers, just understand in which way that is collected so that you are comparing apples to apples each time.
Agreed. Okay, so we have some questions coming up on the Q&A. Thank you guys for placing them there. North Carolina is collecting data by race and ethnicity. Is there a national move to mandate states to collect data by race and ethnicity? I think this kind of follows the answer that you just had given. You know, I think it's difficult when we start doing research projects, especially retrospective data is really just difficult with this, but I think this reminds us as we're doing things prospectively that there is such a difference. But is there a national move to mandate states to collect data by race and ethnicity?
I'm not aware of any sort of, and Dr. Brown, I'm sorry, you can jump into this one as well. I'm not aware of any sort of national mandate that's happened, unfortunately. I think this, as with many things that the COVID pandemic, is happening on a state-by-state basis. What I am aware of is that there are a lot of practitioners and public health officials who are absolutely at the forefront of putting pressure on officials to make sure that that data is being collected. And in fact, I really think a lot of what the CDC published was in response to that. I think to a certain extent, appropriately, they were reticent to publish such a small subset of data that there might be over extrapolations or misinterpretations based on such a small subset. But I think that really was in response to an outcry from physicians, public health officials, et cetera.
Yep, this is Allison. I would agree. I think that there's not much happening on the national stage in that front. I think it's state by state. I do think that Ayanna Pressley and Elizabeth Warren, I think both did try to call for some national level data. And if not, then sort of doing that in Massachusetts. I think in particular around testing and understand who's getting testing. And I've seen some cynical, posts, which I think are not inappropriate, that, it may be the case in this country that if we do highlight that this is a disease that is disproportionately affecting Black and brown people, that may change people's worry about it, which is cynical but maybe true. So I think it may be a double-edged sword, but for sure I think that we need to know what's happening.
Great. There's a question. I'm the only person of color in my MFM group. How do you suggest I get my colleagues interested in racial disparities if there's no interest currently?
Oh,
we're playing a sort of a virtual game of chicken here in terms of who's going to answer that one. I think this is an incredibly important question and an incredibly difficult question. It is human nature to be most concerned with things that tend to affect you and your own personal experience. I think that's a lot of what's at the heart of this concept of othering. When someone is like you, it's easier to be more empathetic. When someone is not like you, those characteristics are more difficult, and empathy is more difficult to embody. I think a lot of the strategies that we've talked about previously, I think number one, if nothing else works, if none of the moral imperatives, et cetera, at the end of the day, there's an economic argument to be made. There are billions of dollars that are wasted in healthcare expenses every single year due to health disparities and inequity that, make no mistake, impact every single one of us. And COVID-19 will be no exception. So if nothing else, I think that argument stands to reason as a reason why everyone should be concerned about these issues. And then I always go back in terms of a more emotional answer, if you will, to Dr. Martin Luther King's famous quote that injustice anywhere is a threat to justice everywhere. If this can happen to any group, it can happen to every single group. So it is inherent and imperative to all of us that we are vigilant and caring for all of those among us.
Cosign. And I think also, please let's send us information at the SMFM Diversity and Inclusion Committee Task Force. We'd love to sort of hear about people's experience if they feel like they are in places where they want to know more about disparities, but nobody else is interested. I think that that's something we should be taking on as a society.
That's great. How about, I have something about postponing tubals. So this person says, my institution is postponing tubals, but not circumcision. So it seems that tubals are much more necessary. Does ACOG or SMFM have a position on tubals?
So ACOG in the initial set of FAQs, and I don't think it has changed, sort of talked a little bit about maybe considering postponing tubals, not because, I think in the beginning of this, we thought, well, it doesn't bring somebody into the hospital that wouldn't already be there and doesn't really extend the length of stay, but it does increase exposure to more members of the healthcare team. So it's a trip to the operating room, the anesthesia team gets involved. And so there was some thought that perhaps they could be postponed. I think in this equity environment and thinking about reproductive justice, we just wanted to put it out there that there are some women for whom, if they don't have the tubal after a vaginal delivery during that hospital admission, they may not have financial access to that, 6 weeks, 12 weeks, whenever we're done with this. And so what we've asked our providers to do is in the outpatient space, understand who the patient is, put it in the problem list. If this is someone for whom getting this done at this time and other like immediate postpartum LARC methods are not appropriate, so that when the patient comes to labor and delivery, we can consider that on a case-by-case basis.
Yeah,
Wonderful. There's
Juliette,
also a comment on,
so SMFM has sort of refrained from being prescriptive on that one issue because there's a huge variation across centers as to how much PPE they have. And for a lot of places, that's driving the decision. And so we haven't been prescriptive about it. But it looks like someone in the box said that Society of Family Planning is coming out with a recommendation soon.
Great.
Perfect. Another question. Can you please discuss COVID-related care for our incarcerated patients? Ideas on how to best care for this vulnerable patient population during this pandemic?
So I'll jump in here. So this is an excellent question and very, very timely. Certainly even here in North Carolina, we've noted that one of the patient populations where we've seen the largest numbers of COVID cases, even in Duke Hospital, have been incarcerated patients. And I think just as we've spoken about with every population, I think they need the highest level of clinical care and a recognition that as providers, when we're providing recommendations to institutions and facilities that are housing patients that we take care of and provide care, that still all the same recommendations that we would give to any other patient in terms of social distancing, hand washing, face coverings, etc., should still apply in that setting as well. And COVID doesn't care whether you're incarcerated or not. It doesn't care what your race, ethnicity is. Doesn't care how much money you have in your bank account. We are all sort of equal in the eyes of this virus, and therefore should all be taking precautions as such.
Wonderful. We've gotten through all the Q&As so far on the box, so we have a couple minutes. Let me just ask both of you a question. You both have done incredible amounts of work in your own institutions. If you had to pick one that you would like to share with everyone, I know you've a little bit talked about it on your PowerPoints, but if you'd like to share one kind of most important thing that you've either learned or you have put forth in your institution that you'd like to share with everyone, could you do so?
I can share maybe the thing that I think that I am most proud of at our total institution level, which was really thinking about telehealth and how that was or was not going to be well served by particular limited English proficiency population. So our institution was trying to figure out what the right platform was going to be to sort of support and recommend for clinicians to use, understanding that there's lots of choices out there. And I think that the one that they thought was going to be sort of the simplest for patients and most patients and providers was going to be an interface that really just allowed a one-to-one interaction. And really, I think that they almost decided that that was going to be the support, but ultimately, the equity voice sort of, loomed large to sort of say that if we can't bring an interpreter into that visit easily, then that really can't be the preferred platform. And so they did a little bit of an about face and went with a platform that would allow sort of a third group to come in. And so I just think that that's what I mean by sort of being upfront and intentional, is that having someone at the table who can think about equity at every single level. I was really quite proud to sort of hear that they had made this very big decision that doesn't involve a huge proportion. I mean, it's a big group of our population. So maybe, 12 to 15% of our patients are monolingual, something else speaking. but it's not the majority, and yet they made a decision that was going to be a default for all.
And I'll just say to sort of after that, in terms of our Duke response, I must say I've been really impressed that we had a town hall early this meeting, and I shared with our division, and I really feel like this is true, that equity has been at the heart of our entire response. Within the OBGYN department. I've been so proud of that. I really can't even take credit for that. So many of the things that I would bring up in terms of equity and inclusion concerns had already been thought of at the highest echelons of our departmental leadership. So I'm very, very proud to be in an organization where equity is so at the center of everything that we're doing. I think importantly, not only has equity been at the center of our approach to our patients, it's also been at the center of our approach to each other. I was part of our redeployment task force as we thought about redeployment as it pertained to our faculty, our staff, and then those implications to patients. And on every single level, we've thought about, if we close down this clinic, what does that mean for that staff? If we close down this clinic and we only see patients consolidated in this area, is that clinic on the bus line? Is that clinic easily accessible? Does the lab servicer for that clinic actually work for different payers and pay structures? So it's been really quite humbling to see how much these messages of equity have actually permeated through what we do at Duke. Certainly we're not perfect, no one is. There's still more and more to be done. And I think this is, I think COVID, as many people have said, this is revealing a lot of cracks in the healthcare system that we already knew were there, but we're seeing just how deep and how gaping these holes are. But we're also seeing how ingenious people can be in terms of workarounds and in terms of their ingenuity with solving problems. And I don't think health equity and inclusion, I think that's included in that as well. I've been overwhelmed by some of the really creative, really thoughtful, considerate solutions that have come up in terms of thinking about all of our providers, all of our staff, and all of our patients.
So I'd like to probably end with the last question here, question about vulnerable research populations. As COVID-19 research in pregnancy is being rolled out, how can we ensure we include women and infants who may benefit most from communities and groups who are disproportionately affected, while making sure to avoid coercion and ensure patient understanding, especially when patients are not primarily English speaking or have limited health literacy? I know you talked a little bit about having research assistants that spoke other languages, but do you also have any other additional kind of tips for those of us that are doing the COVID-19 research?
Yeah, I guess, I think the practical considerations is certainly having folks who speak their native language be able to help and recruit. But I think that the bigger issue really is to how much, what I heard in that was about benefit. And so that benefit in some way is from what we think that the community is going to benefit from, without sometimes I think what we need. And it's, it's really hard, obviously, in this pandemic that is like, hot fire that hit and we needed to scramble and get things done. But in an intentional way, what does the community think that they will benefit from most? So that we make sure that we're asking the questions that the community thinks is most important to them as we move forward, because I think that that's the space where you have harmony and can move forward with community-based participatory research, which I understand that all COVID research is not necessarily, but I think having a community member, having someone who represents the patient population as we think about how to design the research studies would be sort of best practice, but understand that that's challenging in this environment.
Yeah, this is Sarahn. I would just absolutely co-sign everything Dr. Bryant just said. Community engagement and community involvement from the beginning of research, from the inception, all the way through its execution, and then dissemination of the findings, I think is critical and one of the key resources to speak to the issues that were raised. I can't underscore how important that is to include the community, and how important the community can be and community trust brokers can be in the overall success of your research project. You can devise the most beautiful project that you think is going to be so impactful, and all these issues of mistrust, which we've talked about throughout this talk, are going to underlay, and then suddenly your recruitment isn't what you thought it was going to be. And it goes back to, from the inception, including all the relevant parties and making sure that their voices are heard. So absolutely agree with Dr. Bryant's comments.
All right, as we wrap up here, I want to thank you both for your talks and your answering of all the questions in our Q&A. And I just want to highlight next week's special SMFM combined webinar. It'll be with SMFM and IDSOG, so the infectious disease group, with Dr. Sarah Daughters-Katz, talking about treatments in COVID-19, and Dr. Stephanie Ga on vertical transmission and placental effects of COVID-19. So thank you both for your time, and we really appreciate it. And from SMFM, thank you guys for listening.